Good afternoon, everybody. Thank you for coming. My name is Brett Mueller. I'm an ophthalmologist down at Parkhurst NuVision. Very exciting time to be a refractive surgeon. We have so many different new technologies and everything that are coming out. And today we're going to be talking about two of my biggest passions. One, ICL surgery, and secondly, ICL sizing. And how the ArcScan, we really feel, is going to become the gold standard when it comes to ICL sizing. So the first thing that I'm going to kind of go over is just some data that we have on the ICL procedure that we've done. This is some data that I presented last year at ASCRS, where we looked retrospectively at our patients where we put in the toric ICL. And this analysis was done, we looked at 143 eyes, and in our analysis, 143 eyes, 75 patients, and we were looking at best corrected and uncorrected visual acuity, both preoperatively and postoperatively, and to see what our outcomes were. And when we look at our analysis, and this was done over about a 1.5 year long period, so we had about 143 eyes that were in this study, and what we were able to establish is that we are on average able to nail our target 20/20 on average for most of our patients. And then when we look at our mean corrected distance visual acuity from preoperative to postoperative, after we have implanted the ICL, that patients are actually gaining vision that they did not have before, which is just very impressive with this technology. When we look at patients that were not able to see 20/20, so for whatever reason, if they have like keratoconus or if they have some sort of amblyopia, when we do ICL procedure on them, they are gaining about 2 lines of vision or better, which is just incredible and just speaks to how amazing ICLs are for patients. When we're looking at our analysis, we are very good at being able to nail our target with ICLs. We are within 87% of the time, we are within a 1/2 diopter spherical equivalent, and about 99% of the time, we are within 1 diopter a spherical equivalent. Of the 2 patients that are of the 2 eyes where we were not within that 1%, those kind of outliers you can see kind of highlighted here, those patients both had keratoconus where we were treating about 6.5 diopters of astigmatism in one patient and over 5 diopters of astigmatism in the other. So when we're looking at our complications rates in this study, we had a very low complication rate as well. So we have this very good, very safe procedure. So the question is, why haven't refractive surgeons adopted this in the United States? What is keeping them from doing that? We have this amazing technology, a surgical procedure that, after you've kind of done a few, it's not too terribly difficult. So what is the reason? And it all comes down to sizing. That's the most difficult part about ICL procedure for surgeons. And when we think about this, like in terms of ICL sizing, the way that we're taught to do it is by looking at white to white. And if you're thinking about it, if you're going to go and buy a house and you're going to try to see what does the house look like inside the house, or to analyze it, are you just going to look at the outside? No, you're actually going to have to go inside the house, look at it to really see what's going on. And the same thing is true of the eye. If we're going to be implanting a lens and know what's the best size for each patient, you can't just look at white to white. You have to go inside the eye and look at those different measurements and stuff to be able to pick the best lens and the best size for each individual patient. So the way that we've been doing this prior to ArcScan is we use the SonoMed and the SonoMed measurements, and we use 2 different criterias. It was sulcus to sulcus, and then we also use the lens rise. And per this, Dr. Parkhurst has a nomogram that he developed in the military when he was there, and based upon a certain lens rise and a certain sulcus to sulcus, we would then be able to predict, okay, this patient needs a 12/6 or a 13/2, and we've been pretty good at this. We're pretty good at predicting the, about 96–97% of the time, accurately, the right size lens to go in each individual patient. But the issue is, what about those 2–3%? It's the outliers. And that is what can keep surgeons from wanting to do this. You get that one patient, you put in that ICL, and they have a huge vault that comes in, and now they're in angle closure. That one patient can keep you to be like, you know what, I'm not doing ICLs anymore because I do not want to have to deal with these because they can be really difficult and challenging situations surgically. And you have a young patient too. It can be an emergency that you have to deal with. And sometimes being up in the middle of the night, having to manage these patients, it can be challenging. So what if we could have a technology that could eliminate that? And 2, in terms of getting an ultrasound and using a UBM, it can be pretty traumatic for patients. I mean, we've had patients that sometimes have a panic attack sometimes because of this UBM procedure. And when we're talking about refractive surgery, not only do we want to deliver a premium result for the patient, but we also want them to have an amazing experience. And the two challenging parts with ICLs is not the actual surgical procedure, it's the UBM and the PI that we have to do. Hopefully the PI is going to be going away soon once EVO's coming out. And then now with the ArcScan, as I'll show, we have a very good, reliable machine that can take very nice measurements for patients, and the patients are not traumatized at all by this thing. I mean, it's very comfortable for them. So I'm going to talk about some ArcScan data, but initially what I want to demonstrate is just how easy it is on patients to get this ArcScan done. So if you've never seen it before, you just have them just kind of lean in. It's really highly reproducible. The technician does not have to be that well trained in order to be able to utilize the machine. I mean, our technicians are some of the best, but still, it's very highly reproducible and being able to get very accurate measurements, and it's quick and it's fast. And I mean, if you can just look how comfortable our, and this is also one of our technicians here, but I mean, he's very comfortable sitting there, getting very good, high quality measurements, and it happens very quickly. Within a minute, we're able to get some really good measurements here. And again, you're not having to lean the patient back, you're not having to put this like water cup in the eye and getting this like ultrasound probe. It's just very simple, very seamless. And then as you notice, as he kind of like sits back, he's gonna be like very comfortable, very calm. And it's just a lot more enjoyable experience for patients. And just sits back, and it's pretty easy, pretty straightforward. So now, what I'm going to demonstrate too, so this is another video, once you've got the images and how fast and how quick and how accurate we are able to take 7 different measurements inside the eye, that has enabled us to do and putting into an ICL nomogram so that we can get the correct ICL size. And once you get used to it, you can accomplish this in under a minute. So the way that I like to do is at first, you go ciliary body measurements. Then you go sulcus to sulcus. Then take the angle to angle measurement. And you don't even have to, as the physician, you can train one of your technicians and stuff to be able to do these measurements for you as well. So you don't have to be the one that's doing it either. So getting a good anterior chamber depth, getting the angle. And you can like zoom in to get even more precise measurements, which is very nice with this technology. And then you can get the lens rise from the sulcus. No, that one's the sulcus, and that was from the angle to angle. Yep. So now, what I'd like to transition, as you've seen, this device, very easy, very seamless, high reproducibility in terms of like technicians and getting good data. How are we able to predict the ICL sizing in our patients and our patient population? And what does it look like? And so, typically you want to get all these different measurements. You want to get these 7 different measurements from the ArcScan. And then what you do is you then input it into the ICLsizing.com, which is Dan Reinstein's website. And then from there, it will then tell you prediction-wise of what the predicted ICL vault size will be post-operatively. So after you've tamed all these different measurements, and this is kind of like what the image looks like, you then log on to ICLsizing.com, which is free, and it's London Vision Clinic with Dan Reinstein. And you input all this information, so it's 11 different data points for each eye. And then with that, it gives you a prediction of what the actual lens vault would be. So in this particular patient, we like to stay around about 500 microns, so we would probably pick like a 13.2 or perhaps a 12.6 for this patient, for this ICL size, but more likely a 13.2. So we wanted to see how accurate is this in our practice and what are we seeing with the data. And when we look at it, so this was a retrospective study that was done, and so far we have 160 eyes that are going to be included in this study. We've already analyzed about 86 of them. And what we have found so far, so this is a scatter plot looking at that, we are able to predict on average and be within 54.7 microns of prediction of what Dan Reinstein's website is telling us. We then, when we look at it, and again, it's the outliers, but we are within 97% of being able to predict within 300 microns what the actual lens vault size will be. And if you think about it, that's the half of a width of the cornea, so very impressive data. And we are, there are some 3% where it's going between 450 and 301, but even still, the lens vault size was still very good in these patients as well. So what we feel like with this technology and what we've seen, we've had a 0% rate of ICL sizing either being too big or too small with this technology. Too big being like 1,000 microns, too small being about like under 150 or 100 microns. So no instances of angle closure, no instances of cataract formation to date, no instances of ICL rotation utilizing this device. We are within 97% of the time able to predict within 300 microns of what the actual vault size is going to be. And I really feel that this technology is going to, and this level of accuracy, we can anticipate more adoption of surgeons doing more ICL procedures and feeling comfortable with this technology and being able to offer it to a more wide array of patients across the United States. So with that, that's it.
Thanks, Brandon.
Any questions?
Thanks, Brett. I think you really told the story of this sizing nomogram very well. And you're right. When we were using the prior UBM device, we were pretty happy. Maybe once or twice a year, we would still have an outlier, which is not fun. An outlier means you have to go back in the eye. If the lens is too small and the toric rotated, you have to do an ICL exchange for a bigger one. Or if the lens is too big and you've got a pressure crisis, that's really no fun because the patient's in pain. They may be having nausea and vomiting. They're a young, healthy patient. They've just paid a lot of money to have this transformative event, and now they're dealing with a true emergency. So that is just not something that's fun to deal with. And so even though it didn't happen often, to take that from rare to zero is a game changer because you need it to be zero in a refractive practice. And then also the other thing that I think you pointed out perfectly, when you think about the predictability of being within 300 microns of predicted 97% of the time, that is incredible accuracy. 300 microns. So that is where we can start to talk about. We've alluded to this topic in the past. Well, what if we can now get to the point with ICLs where we can prescribe a certain vault to a certain patient? Because you're right, like in that example you showed, we predicted a 12.6 might give us 400 microns or whatever it was versus a 13.2 might give us 650. In a patient with a very large chamber, we may prescribe the larger vault in that scenario versus a patient who has a smaller chamber depth, 2.8, whatever. We may decide to prescribe a smaller vault. But with this imaging modality, and really its combination with Dan's nomogram, because they can't live independent of each other. It's those two things together has taken us, I think, to a completely new level with ICL surgery. And I think that ICL surgeons need to use this if they really want to grow their ICL practice.
Has it had an impact on your cornea refractive practice as well?
Oh, for sure. All of that plays together, right? Because the word of mouth around refractive surgery, the reviews that you get when you, like Brett said, not only deliver an incredible outcome, but also a very comfortable experience. That leads to word of mouth referrals for every procedure that we do. And so that they all feed off each other.
And integrating this into your practice, how was that? Into the workflow within your practice?
Well, it's made our UBM diagnostic step simpler and more streamlined. Like Brett said, we've been doing UBMs with another technology for years, but it's been a much bigger ordeal. I mean, it takes probably a half an hour to lean the patient back, get the cup in. There's a lot of training involved to get the techs up to speed on how to get a good scan. you pointed out that with this newer nomogram, I don't think the surgeon has to be the one doing the measurements anymore. But before this, we were. So, we'd spend 10 or 15 minutes at the computer with the prior UBM deciding what size we were going to use. So there was a lot of time sink. It was worth it. We believe UBM technology is better than white to white, but it was a huge time sink in the past. And now we can delegate a lot of that. It's easier to train the techs, so many techs can all do it. And we can train the techs to even put the calipers in and then plug that data into the website. So it's made our time as surgeons much more efficient. It's easier on the patients, easier on us. Yeah.
Concern would be like data entry errors. Like what is your process just to make sure that double check, triple check that the data that you are measuring manually here is actually entered correctly into the calculator?
Totally understand the question, right? So with any refractive surgery we do, it's ultimately the responsibility of the surgeon to ensure that there's been a quality control process, that there was not a data entry error. But we're used to doing this all the time. For example, when we do LASIK surgery, we have to make sure that the data is entered into the laser properly before we step on the foot pedal. In this instance, we have to be sure that the data was put in properly before we order and implant that lens. So of course, there's still an opportunity for human error, but that's no different than what we're used to with cataract surgery or anything else, is making sure that it's good data before we select the surgical treatment we're going to do.
But we actually have a printer that's hooked up to our ArcScan, and you can print the image out. In combination, you can also print out that page of that ICLsizing.com nomogram, and then you can verify and double check that way as well. So that's also another thing that we do is to kind of do that.
I think it's a great point.
And the plus minus 300 that's on the ball?
Yes.
Yeah, plus or minus 300 on the ball.
How does that compare if you just use your white to white from ArcScan or from other devices?
Well, that didn't exist. Before Dan Reinstein's nomogram, there was no such thing as a table that said if you use this size lens, your vault should be X. We had nomograms that said if you want to avoid outliers, then use this size at this sulcus to sulcus measurement. So what he's not saying that the vaults are plus or minus 300, they're plus or minus 300 of predicted based on the nomogram. So like for example, if it predicts that our vault with a 13.2 lens is going to be 600 microns, it's going to be within 300 and 900 97% of the time, which is a happy zone.
Yeah. Any other questions?
Have you found ciliary cysts? Have they surprised you? You already used the sonogram, but what kind of a percentage of patients have the cyst been discovered here and realize that wow, we need to do something different?
I wouldn't say that it's super common that a cyst will change our surgical management, but it happens occasionally. Maybe once or twice a year we find a cyst that's there. I have had a couple of patients in the past where a large cyst in the 180-degree meridian would cause me to decide to implant the ICL vertically instead of horizontally to avoid the cyst. Now, of course, you can't do that with toric ICLs because you got to put it in a very particular place, but with a spherical ICL, sometimes a large cyst may cause us to alter where we put the lens.
Have you talked to other surgeons about the difference in sizing of the current lens versus the lens that hopefully will be approved soon? Are there any difference between sizing of the two lenses?
We're not really permitted to talk about future technologies that don't have FDA approval yet, but what we're seeing is, I think, all the nomograms that we use for sizing are going to be pretty similar. Mm-hmm.
Have you looked into the data, like compare, like what the white to white lens length you have recommended versus using the ArcScan?
We're going to be doing that. So that's going to be in our data analysis and stuff once we've collected all. But yes, we'll do that and say, what would the white to white measurement have predicted, and then how is that different from what the ArcScan, and what percentage of that, and how big of a change is that going to be? So yeah, that is something we're going to be looking at with our data.
Use like different white to whites, like Nesta white to white, Ion Master 500,
I mean, we typically use the Pentacam. We're not going to have those different type of measurements. It'll just be the Pentacam white to white that we'll utilize. Yeah.
Just with our prior experience using UBM compared to what the white to white would predict, we have been for years using a different lens based on a UBM nomogram about 40% of the time. It's not a small percentage where the UBM is guiding the placement of the ICL size we're going to pick. And it got to the point where we basically stopped even paying attention to what the white to white was. We were using UBM as our primary sizing data.
All right, thank you guys.
Thank you.
Thank you.